Good morning. We are happy that you all are here. This is session 214, discussion with a doctor about anaplastic thyroid cancer and Hürthle cell thyroid cancer. What is new? My name is Brittany Avon McKelvey. I'm a papillary thyroid cancer survivor, originally diagnosed when I was 13, and here to help moderate our session with Dr. Lorch. And I also have the pleasure of introducing him. Our speaker, Dr. Jochen Lorch, he is a medical oncologist and professor of medicine and medical director of the head and neck and thyroid programs at Northwestern Medical Group in Chicago, Illinois. He graduated from the University of Regensburg in Germany and completed his internship and residency at the University of Pennsylvania Presbyterian Medical Center. He was awarded a fellowship in hematology and oncology at Northwestern University in Chicago. And in 2002, he returned to Germany to complete his German board certification in internal medicine and medical oncology. He returned to the US in 2005 to take a faculty position at Boston University in Boston, Massachusetts, and started as a faculty member at Dana-Farber Cancer Institute in Boston in 2008. He became the inaugural director of the Thyroid Center at Dana-Farber, and most recently in 2021, he left Dana-Farber as associate professor of medicine to join the faculty at Northwestern University. Dr. Lorch is a ThyCa medical advisor, and we are so happy to have him here to be able to talk with us all today. So I will turn it over to you now, Dr. Lorch. Thank you so much for taking your Saturday morning to be with us.
Thank you so much, Brittany. And yeah, it's a real pleasure to be here again. And I wish it was in person rather than virtual. But anyway, it's just how it is. In the past, I've always tried to keep these sessions as interactive as possible, and I think that's worked well. I'm not sure. So if you want to interrupt, that is totally fine. In fact, that is welcome. So just unmute yourself and just speak up. And you can also submit some questions if you raise your hand here with that raise hand button. Whatever, the more interactive and the more we can actually talk directly, the better. So let me start sharing here. So I have this interesting combination of Hürthle cell cancer and anaplastic thyroid cancer. And as you probably know, well, first I have to say that for some reason this still has a lot of Dana-Farber background here, but this is my affiliation. I'm at Northwestern University. This is also my email, so do not hesitate to reach out and send me an email. And this is it. Or instead of nm.org, also northwestern.edu. That also works. So Hürthle cell cancer and anaplastic thyroid cancer are certainly among the more aggressive ones. So that's one of the reasons why they're grouped together. The other reason is, of course, that we just opened a trial for these two groups specifically, and I will talk about that in a little bit, and the reason why we're doing that. But in general, I mean, as you know, many of you are hopefully survivors of anaplastic or Hürthle cell, but you all know that they are pretty aggressive. Anaplastic thyroid cancer in particular, I think the prognosis has dramatically changed over the last couple of years, mostly due to two things. First, the advent of the BRAF inhibitors, which do have a high response rate. They don't cure anaplastic thyroid cancer, but they have a high response rate. But then also to a large extent, immunotherapy in anaplastic thyroid cancer. Hürthle cell cancer falls into the category of differentiated thyroid cancer. So differentiated thyroid cancer is essentially all these thyroid cancers that people have. They undergo surgery. It's very common, 60,000 cases per year in the US. People undergo surgery, maybe a little bit of radioactive iodine, and then it's gone and nothing ever happens. In a few cases, in a few patients, this comes back. And because Hürthle cell cancer does not respond to radioactive iodine in general, the Hürthle cell is overrepresented in this group of patients where thyroid cancer comes back. So among all these very few handful of people where thyroid cancer comes back, a substantial number, about a third or so, of patients where this happens do have Hürthle cell cancer. So it's not, I don't think it's per se growing any more aggressively than most other, say, papillary or follicular thyroid cancer. So it falls into this group of follicular thyroid cancer. But it just tends to recur more frequently. And then when it does recur, it's not responding to radioactive iodine. And then you go down the route of tyrosine kinase inhibitors and so on. So with anaplastic thyroid cancer, again, that's sort of a category of its own. And so it's a little bit of an awkward combination to be talking about these two. But again, a lot of things actually apply to both. So there's some research support. And as you know, there's a really poor prognosis for anaplastic thyroid cancer. And Hürthle cell cancer falls into this follicular category. So most people are actually definitely alive. Most people also are cured of Hürthle cell cancer. So that's also a frequent thing about Hürthle cell cancer, that you know, when there are Hürthle cell neoplasms and there are Hürthle cell cancers. And so if you have, you have a nodule, you have a biopsy, and out comes a bunch of Hürthle cells. They aspirate, you get a fine needle aspiration, out come a bunch of Hürthle cells. Does that mean that you have Hürthle cell cancer? No, most likely you actually don't. There are Hürthle cells there are even Hürthle cell nodules in the thyroid gland, or heaps of Hürthle cells in a normal thyroid gland, and you cannot tell whether somebody whether this is Hürthle cell cancer or whether this is just a Hürthle cell adenoma, for example, like a benign Hürthle cell accumulation. So not everybody who has Hürthle cell or where the pathology report mentions Hürthle cells, not everybody has Hürthle cell cancer. Now, again, and because Hürthle cell cancer is part of this differentiated thyroid cancer group, not everybody who has Hürthle cell cancer will have a recurrence, which means like the cancer coming back. And an even smaller fraction of people, even if it does come back, will require actual treatment. So generally, these are relatively, compared to lung cancer and certainly compared to anaplastic thyroid cancer, these are often relatively slow-growing tumors. Now, if you look at Hürthle cell and anaplastic thyroid cancer compared to other types of cancer, breast cancer, lung cancer, prostate cancer, it's generally not having, there aren't a lot of mutations. And actually for Hürthle cell cancer, it's even famously so. They have even fewer mutations than the regular differentiated thyroid cancer. So the regular papillary thyroid cancer, the regular follicular thyroid cancer. BRAF mutations, which are here in this greater schema, are mentioned as sort of the only mutation that's worth mentioning in thyroid cancer. Well, there are a few more, but BRAF mutations, for example, in Hürthle cell cancers do not occur. So, or almost never occur. So it's been a little bit of a mystery what's actually driving Hürthle cell cancer. And it turns out there are certain mutations in these things called mitochondria. Mitochondria are essentially the structures in cells. We all have them. These are little structures in the cells that essentially produce energy. And they pretty much resemble bacteria. And once, many, many millions of years ago, all mammals have them, millions of years ago, it was probably bacteria that somehow got into these cells, and the cells found them useful for producing energy. And that's why we kept them. They're also passed down from the mother only, and so on. So there's a couple of funny things about them, but they have their own DNA there. So that's where they still resemble bacteria. And it turns out that there's plenty of these mitochondria, much more mitochondria in Hürthle cell cancer cells than in differentiated thyroid cancer cells, for example. So people went on and sequenced this DNA from this, which is separate from the general genome, these 20 odd chromosomes. It's the chromosomes that are, again, very bacteria-like this. It's a ring. It's not like chromosomes, but it's just one ring, and so on. Anyway, so there are certain mutations that seem to affect the DNA in these Hürthle cells. And there seems to be an accumulation of these, of certain types of mutations that do affect the production of energy in the cells. The problem is that just like bacteria, these mitochondria are pretty bad at actually repairing their DNA. We're pretty good at it. Bacteria live for a few hours and then they're dead. So they don't really need to repair their DNA. We live, hopefully 100 years. And, for us, it's absolutely crucial to be able to repair DNA. But because they're so sloppy with their DNA, there tends to be lots and lots of mutations that they acquire. So it's still not clear, is this just a coincidence that they have these mutations because they have mutations all over the place? Or is it actually meaningful? What they also have is that, again, this 23andMe chromosomal thing. So there are these chromosomes, and there's two sets of them, one from your father, one from your mother. And they're essentially coding for the same genes. And in Hürthle cells, not not germline, this only happens in the tumor. What we find is that there's a near complete what's called haploidization, which means that there's only one set of chromosomes left in these Hürthle cells, Hürthle cell cancer cells, except for chromosome 5 and 7, where, but it's so it's a little odd. That does occur in certain cancers, and it's certainly meaningful because if you only have one set of chromosomes, if you have a tumor, if you lose any one of these tumor suppressors, things that suppress the growth of cancer or of any cell, you lose that. Well, if you're healthy, you have the other set, you lose your mother's set of chromosomes and for one suppressor, well, you still got your dad's, which will usually make up for it. But if you only have one set, which is what these cells have, so they lose a tumor suppressor, there's a much higher chance for something bad happening. Then, this is just, just generally in differentiated thyroid cancer, there aren't a whole lot of mutations. Again, there's BRAF, so these are all, so each little bar here is a person. And, and then these are the sequencing results. So this person here, for example, has a BRAF mutation, and then some mutation in a gene called PPM1D, which is not of any major significance. But anyway, it's there. So generally, the gist of what this slide is supposed to tell you is, generally, compared to lung cancer and breast cancer and so on, you would have lots and lots of these little sticks here because there's a lot more genes that are involved. In thyroid cancer, there isn't a lot going on genetically. Different story with anaplastic thyroid cancer, which is here, and poorly differentiated thyroid cancer. Again, there's all here. Each bar here is a person, and again, you have about 45% of patients have BRAF mutations. Then you have a couple of other mutations, and then there's a lot of stuff going on here. TERT, for example, TERT is bad. If you have a TERT mutation in thyroid cancer, then your chances of developing iodine refractory disease and going down the rabbit hole with lenvatinib and all this other stuff is just a lot higher than if you don't have that. And then there's a bunch of other stuff here. These are epigenetic mutations, very interesting, but we can't target them yet, although we're working on that. So as you know, this
Lorch, maybe before you go up, we're getting a lot of questions in the Q&A, and I think your previous slide kind of showing poorly differentiated and anaplastic. We're getting questions about kind of what is the difference there and how poorly differentiated fits into this talk about anaplastic. And so maybe wanted to pause while you were on that slide to kind of, if you could discuss a little bit the differences there and maybe similarities.
Yeah. So that's a really good question, because that to distinguish between poorly differentiated thyroid cancer and anaplastic thyroid cancer, just by looking through your microscope, which is what the pathologists do, is very difficult. There are certain criteria, like for example, if you have extensive area of dead tumor tissue, then that argues it for being anaplastic thyroid cancer. And then there's a number of other things. There's also anaplastic thyroid cancer, for example, comes in a couple of special flavors, I guess you could call it. So some of them have this, they look like squamous cells under the microscope. They're not, they're still thyroid cancer cells, but, and that's why they're called squamoid, anaplastic thyroid cancer. Or sometimes they look more like sarcomas, which are more like spindle cells. And if you see anything like that, then it's pretty clear that it's anaplastic thyroid cancer. But in many ways, you do often still rely on just clinical picture. So if you have somebody who has a very rapidly growing neck mass, that sounds more like anaplastic thyroid cancer. On the other hand, can poorly differentiated thyroid cancer grow at a similar rate? Yes, absolutely. And I've seen it many times. The biggest difference, and that's why the distinction is important, and we'll also talk about that later. The biggest distinction is that poorly differentiated tends to respond beautifully to things like lenvatinib and sorafenib and all the other NIBs, whereas anaplastic does not. Lenvatinib in anaplastic has no role. There was initially some hype about it, data coming out of Japan. They treated a handful of patients and saw about 10 patients and saw nice responses in the majority of them. But then there was a trial where that was done here and, real, like with a protocol and entry criteria and so on. And not to dismiss what they did in Japan, but it was just, they just took the drug and gave it to patients and just recorded what they saw. But it wasn't a real trial. Whereas then there was a real trial where, with entry criteria, patients being screened and so on. And there it turned out that that trial was actually stopped early because among more than 30 patients, there was only one person who responded. So poorly differentiated lenvatinib works beautifully in poorly differentiated. In fact, if you look at this trial that I'm sure you're familiar with, this one, the SELECT study, that was this big randomized study, where people got placebo versus lenvatinib, and that led to FDA approval. And because you had this really nice, strong difference between people who got the placebo here, so they progressed much faster than those who had, who actually received the drug. There were 4 complete responders, and 3 of them actually had poorly differentiated thyroid cancer. So complete response means the tumor disappears and you can't see it on a scan anymore. Does that mean that that the cancer is cured? No. If you stop the drug, it'll come back. But still it responds, and often it responds really well and for a really, really long time that can go on for years. Anaplastic, not so much. So that's why it's important to distinguish between these two. If you look at it genetically, and especially if you compare that with this, like this study was done on 400 odd patients who just had what a lot of people go through. They go to the primary care doc, a nodule is felt in the thyroid, you get an ultrasound, looks a little suspicious, have a fine needle aspiration, it turns out it's cancer, then undergo surgery, and then they're done. Most of the cases here were actually in that category. So the 95% cure rate is among these. So there's only a handful of patients who had something worse than just the most frequent form, which is just papillary thyroid cancer. So this is why this here, and especially that here in anaplastic thyroid cancer, this is very different from the format is different. Obviously, the table looks different, but if you compared this and put this in a similar format, these are all meaningful mutations. These are all things that mean something and that are driving cancer. If you put your papillary thyroid, a regular papillary thyroid cancer in this category, maybe you would have in about half of the cases, you would find this BRAF mutation, which again is up here, BRAF. and a few NRAS and so on. So that's sort of very reminiscent of this bar here, right? So this is BRAF and these are the RAS mutations. But otherwise, the rest here in well-behaved differentiated thyroid cancer would look completely blank. So this is very different, and you can, but also even comparing poorly differentiated over here versus anaplastic over there, just visually, you know, I mean, there are fewer cases because it's more rare, fortunately, but you know, there's a lot more going on. Does that answer the question?
Yes, thank you.
Okay, good. Any other questions at this point?
I think one relevant, there's a couple, you know, very specific, which I want to leave to kind of the end to make sure you can get through things. But there's one question which I think is really relevant here as we're talking about the different genetics and all of these mutations, about kind of thinking about when to get genetic testing and the frequency if a patient has undergone surgery and treatment. But is there any kind of advice or thoughts you have as far as the frequency of testing and genomic testing in general?
Right. So you got to keep in mind, most people with thyroid cancer are cured. So I think that everybody who has a thyroid cancer diagnosis should be tested genetically? No. I think, you know, again, in most cases it's gone and it'll never come back. And, you know, why do it? Now, if you live in a number of states, including the great state of Illinois, then genetic sequencing is actually covered. There's a law that requires the insurer to cover cost of sequencing. So you can actually have it done. And if you feel like it, then, you know, go ahead. Now, the problem is, if you will get a result, and then happens not infrequently in my practice. You get a result, and then you got to live with it, and that can be more tricky than you know, you sometimes imagine it to be, because then you say you have a BRAF mutation. Well, if you have a BRAF mutation, then your risk of the cancer coming back, but also your risk of dying from this, is increased about 2.5-fold. So now, if you think of it, that if you think about, so your diagnosis, papillary thyroid cancer, BRAF mutant or not, the cure rate is somewhere approaching 100%. So if your risk of having a recurrence and dying from this is 2.5-fold, then yeah, maybe your chances of being cured from this drop from 98%, to 95%. Well, that's still very, very good. And all you've done is, caused yourself some sleepless nights, because now you got to think about and learn about BRAF. And if you click around on the internet, you'll see all kinds of things. I mean, it is, it's a driver. It contributes to this. So I think, so upfront, for curable cases that are just middle of the road, no risk factors, not an unusual number of lymph nodes involved or anything like that, I don't think genetic sequencing is useful. In fact, it just causes, there's this potential of causing anxiety. Now, for everybody where the cancer comes back, I do it. It's pretty much the first thing I do. And I would recommend that no matter what. If there's any issues with thyroid cancer either coming back, even if it's curable surgically, because the recurrence just happens in the neck, or if it's an unusual histology, something like a component of poorly differentiated thyroid cancer, anaplastic, of course. For anaplastic, do it right away. But we get it for everybody. And then it's always useful. There are three main, and I have a few slides for that, but maybe just so we get to more questions, I'll just tell you about it. So there are three major mutations that play a role, and then there's a fourth one that plays a small role. So if you have anaplastic thyroid cancer or Hürthle cell, but again, Hürthle cell, you don't usually find a lot. But if you have anaplastic thyroid cancer, there are three mutations that matter. One is BRAF, one is RET fusion in that case, because RET mutations, which also occur, but they play a role in medullary thyroid cancer, not so much in anaplastic. In anaplastic and papillary thyroid cancer, you have these RET fusions, but it's just a different name. And it's included in all these panels by now. So it's BRAF, RET, and then something that's rare, also a fusion called NTRK. And because they're important because we have specific inhibitors for those. We have BRAF inhibitors in anaplastic, usually combined with a MEK inhibitor. We have very good RET inhibitors. Everybody responds. In anaplastic, still a question. Usually the response is not terribly long, not as long as with other thyroid cancers that are RET altered, but still, that would be, if you have that, that would be my first choice. Get on one of those new RET inhibitors. And then NTRK, which is another tyrosine kinase and another pill that was developed that's specific to this particular tyrosine kinase. And again, side effects are negligible of these pills, and everybody responds. Again, questions about for how long, especially with anaplastic. But if you have any one of these, you should definitely use that. There's a fourth one, which is called ALK. ALK plays a big role, so ALK. That plays a big role in lung cancer. In anaplastic thyroid cancer, it turns out it's actually extremely rare. And so it usually doesn't apply. But if you have it, again, there is another tyrosine kinase inhibitor that's pretty specific to this. It also covers NTRK for the most part. But anyway, if you have one of those, then they're good drugs and you should be on them. Beyond that, things like total mutational burden does seem to correlate with response to immunotherapy. That's also something that you can't check unless you do next generation sequencing. And then also just if you look at that profile, for example, we know that if you have one of these mutations here, PI3 kinase, PIK3CA mutations like this here, or AKT mutations, that usually means that the prognosis is, or the growth is pretty aggressive. Same for TERT. We can't target these things. Well, we can target this, but we can't target TERT, for example. But these things are mostly useful to figure out why the tumor is behaving the way it does. And then in some cases, you can make an attempt to use that therapeutically if you need. But it also gives you a rough idea of what the chances are might be to respond to immunotherapy. And actually, maybe let me just, unless there's another burning question.
Yeah, I think this is all relevant. So go ahead.
Okay. Okay. Anything else that I should talk about now before I go to immunotherapy?
I think this is, a lot of the questions are all aligned kind of about treatment. And so I think if you get through that, and then we'll readdress
all right,
the questions.
Good. So this is all old stuff here. This is the response in anaplastic thyroid cancer to BRAF inhibitors. So the majority get a response. This was in 16 patients treated with the BRAF inhibitor, led to FDA approval. It's MD Anderson data. And not that they're making stuff up, but things tend to work at MD Anderson. And I think that has mostly to do with the patient population that they're seeing. People fly in from all over the place. So, again, it does work. I am just not sure if there's a 70% response rate, not in my experience. And other people like at Memorial Sloan Kettering feel the same way. Anyway, so this is about RET. We briefly talked about it. I'm not going to spend much time here. Medullary thyroid cancer. This is these are the RET inhibitors. But anyway, this is all. These are the two RET inhibitors. Again, let's not spend too much time there. This is about ALK. This is a patient with anaplastic thyroid cancer. It's very rare. I've seen only one case so far, and this is also a case that was reported. So there's no large data. There's certainly a response rate, so that's why you need genetic testing done. And there's a good chance, or there's a chance that you may have it, but there's not a good chance. It's really very, very rare, probably less than 1%. This is NTRK, the way these fusions work. And then again, if you have an NTRK fusion, almost everybody responds. Now, this study, of course, it's rare. So it took a long time to collect these 55 patients, and only the green bars here, actually the light green ones here, there, are actually thyroid cancers. But essentially everybody who has this fusion response. So if you have papillary thyroid cancer or anaplastic thyroid cancer, there was one ATC case in this series. This is a great option to get treated, and everybody responds. Everolimus, also a drug that's frequently overlooked in, because it's old. It's derived from rapamycin, which has been around. Well, it's actually made by some certain bacteria in the soil of the Easter Islands, Rapa Nui, as the island is called in the local language. Thus rapamycin. And there's everolimus is one of them. There's several. There's a handful of them. They work really well, especially in Hürthle cell. We also saw quite a few responses in anaplastic thyroid cancer, and one of those cases we actually published in the New England Journal. This is everolimus in Hürthle cell, so a lot of stable disease. So we selected for patients who progressed within 6 months. So these were very aggressive cases, and it took a while for all of these to progress. This was our sequencing, and again, that was because we selected for such aggressive behaving tumors. There was a lot that we found. So again, this is different from the papillary thyroid cancer that's just removed and done. And these were all cases that patients who had run into problems. So immunotherapy. So it started out with this checkpoint inhibitors, things like pembrolizumab, Keytruda. You see it on television all the time. And you will, because until the patent expires, which will be in about 4 years. Anyway, so there was thyroid cancer was of course tested, and overall the results were very disappointing. Two out of 22 patients with iodine refractory thyroid cancer responded. That did include 1 or 2 patients with Hürthle cell, but generally, from there on, people were not thinking that this was anything worth pursuing. Now, because anaplastic thyroid cancer has a higher rate of mutations, there was one trial which was done through Novartis, a drug called spartalizumab, that's a PD-1 inhibitor, and that actually responded in a 19% radiographic response rate. And then I have some of the slides. And then there was this thing. So I was at Dana-Farber at the time, so now I guess the Dana-Farber logo is appropriate. I was working with somebody called David Barbie. He's actually a lung cancer guy, and he had established a model system in his lab where you essentially take tumors, you grind them up, but in a very sort of cursory way, and you let them grow, but only for 1 or 2 days. And then these cells, these tumor cells, sort of grow into these little globs of tumor. And but the trick is, and that's been around for a long time, the trick is it will also leave all the immune cells intact. And if you look, for example, and this is only over the course of 2 hours, because the cells don't survive the conditions of having these pictures taken all the time. That requires a lot of light. Anyway, but you can see sort of all these immune cells kind of dancing around this glob of thyroid cancer cells. And especially here, sort of in this corner, you can see how it's sort of starting to melt away. And again, this is only over 2 hours. So started again. I think it starts again automatically. So I always get excited when I see this. So there you go. You see this cells dancing around, and see how it's sort of around this edge. Things are starting to melt away. Anyway, when you let this run over a whole day, then you actually see a lot of dead cells. So that was the basis for a trial that we did. In the meantime, also another trial came out, although it wasn't really a trial. It was actually what's called a cohort study, which is again similar to what they did in Japan. This time, this was actually done in Germany. So they took 8 patients, they treated them with pembrolizumab plus lenvatinib. They all had anaplastic thyroid cancer, and treated with this regimen. And then amazingly, 75% had a partial response. So among those 8, 6 actually had a partial response. So that created a lot of enthusiasm. And there's a trial that's ongoing now. It's testing this. it's interesting because pembrolizumab alone would be similar to the PD-1 inhibitor alone. So, there one would expect a response rate of, 19, 20%, something like that. Lenvatinib by itself doesn't really work. So the question is, if you throw the two of them together, do you get not just the added effects, do you get something that's called synergy? So, things working together and enhancing each other's effects. And, these data really suggest that this may be the case. Now, the idea that lenvatinib in conjunction with immune checkpoint inhibitors, such as pembrolizumab or nivolumab, or, there's a number of them around, the idea that this could actually happen has been around for a long time. And then there was another trial that was done where these two drugs were combined. It was a phase 2, so there was no placebo arm, so everybody got treated. And then you compared it with historical controls. But because we have so much data on lenvatinib, the historical control is pretty solid. And it turns out there was definitely no synergy. The results looked basically identical to just lenvatinib alone. So who knows what pembrolizumab does when it's added to lenvatinib in differentiated thyroid cancer. Now, is this so different in anaplastic thyroid cancer? Nobody knows. I have treated, there's a lot of off-label treatment, which means you can get Keytruda and you can get lenvatinib. So then, people are being treated without a trial with this. And it's not good, but I've done it. I'm doing it actually. I'm not sure if it's better than just pembrolizumab alone. I see a lot of mixed responses, partial responses, like everything shrinks by at least 30%. Does it happen very often? No. Have I seen shrinkage? Yes. But often is what I just mentioned is a mixed response. Some lesions grow, others respond. And then the question is what to do. And sometimes what we do is we go around, radiate the few lesions that have grown, or if there's just one lesion that has grown, then we radiate that and keep people on that regimen and so on. So then it gets just a little murky. I think we'll have to wait for the trial to finish. Again, it's not a randomized study. It's not, we won't have a control group. It'll be compared with historical controls. We'll have to see. There may be synergy, but maybe there isn't. What we did though was essentially, this is this little device that David Barber developed, and we saw lots of responses in the little device. And then, that's the same data. So this is what these cells look like under the microscope. And then when you treat them with a checkpoint inhibitor, they die. And especially when you treat them with a CTLA-4 inhibitor. So that's one that's not pembrolizumab or spartalizumab or any one of the others that I just mentioned. That's a different one. It's called Yervoy or ipilimumab. And it's actually FDA approved for melanoma, and it is clear that it's better than just one checkpoint inhibitor alone, to pembrolizumab alone. If you add a CTLA-4 inhibitor, you get a higher response rate in melanoma, also in non-small cell lung cancer, where you sometimes that often responds to checkpoint inhibition. So that was the basis for our trial. That's what we did. Essentially, we included about 50 patients, most of them with iodine refractory thyroid cancer, just because a third of all thyroid iodine refractory cases are Hürthle cell cancers. There were about 12 patients with Hürthle cell cancer also in this group. And then we also did this, we also treated 10 patients, initially 5, then 10 patients with anaplastic thyroid cancer. And that was really the group that benefited the most. So here, anaplastic are the bars in blue, and I think I have them. These are just the anaplastics here. And so this is, definitely very encouraging. And now the nice thing about responses to immunotherapy is that not only do things respond, if tumors respond, not just anaplastic, but cancer in general, if cancer responds to immunotherapy, there is a good chance it will go away and it will not come back. Chemotherapy can't do that. Lenvatinib can't do that. All the wonderful RET inhibitors and NTRK inhibitors and all the others, if you stop the drug, even if you have a great response, you stop the drug, it comes back. always, not in immunotherapy. That's the promise of immunotherapy, and that's why I think that's real progress. So these are just a couple of cases here. This is somebody with anaplastic thyroid cancer at 2 months already, much shrinkage. Actually, she was 87, and she then was treated for 2 years, and then we stopped per protocol. And the cancer has not come back. The last I heard was she's still alive and over 90 years old now. And the cancer is still off treatment. The cancer has not come back. Plays golf, does all kinds of things. Similar. These are. So I think it's really sort of immunotherapy is really the new chapter here in thyroid cancer. So based on that, based on this, we then first I tried to convince Bristol Myers to fund a bigger study for anaplastic thyroid cancer, and they wouldn't. So right now we're pursuing that through the NCI, and hopefully that'll open. But the NCI is very, very slow. So if that trial happens at all, it's going to happen in a few years down the road, probably. Meanwhile, I've reached out to a company that makes a bispecific antibody. Bispecific antibodies are the newest and greatest thing in oncology right now, in immuno-oncology specifically. So these are, pembrolizumab, Keytruda, all of these are antibodies. They're infused. They're little protein structures. You can't eat them. I mean, you can, but then you'll just digest them and get a little protein. But these are things that look like little Ys, and because and the tips of the Ys is where the antibody binds to what's called the epitope, which is essentially the thing that it recognizes. And then the stem of this Y, that basically tells all the inflammatory cells to come in and do their thing and destroy this, because there's something going on that's not supposed to be there. Typically, for like antibodies, you have the same binding on both arms. Like Keytruda binds the same on arm 1 and arm 2. PD-1 in this case. Yervoy binds the same on CTLA-4 in both arms, arm 1 and arm 2. So what's happening now is that people are making these antibodies where you have one arm of that Y structure that binds to one thing, and then the other arm binds to something else. So it's essentially combining both it's combining two drugs in one, and essentially like Yervoy and pembrolizumab. And so we just opened a trial where we're using this antibody, and we're hoping to at least replicate what's happening here. There is also the possibility, because they're binding two different things on each molecule, it also brings inflammatory cells and tumor cells together. So the response could actually be better. So there's some, not in thyroid cancer, again, we just started, but in some other cancers, there is some credible evidence that that may actually happen. Now, how is this relevant to Hürthle cell? The other topic here of this talk, among those 12 patients with Hürthle cell in the same trial, we actually saw about half of them also responded. There were a couple of Hürthle cells with that fell into the Hürthle cell poorly differentiated category. But also in just middle of the road Hürthle cells, we saw some really nice responses. So that's why this trial with this novel bispecific antibody that's binding CTLA-4 and PD-1, that's why that's why it's open for Hürthle cell. And it opened 2-3 weeks ago, and we have 2 patients already, but just starting treatment, so I can't really tell you yet how that's going to be. What else is out there? Well, there's lenvatinib plus pembrolizumab. There's still a number of trials. There's also the attempt to combine BRAF inhibitors and just add Keytruda. Again, when BRAF inhibitors are available, Keytruda is available, so stick it together. My feeling is that there's actually Maria Cabanillas at MD Anderson, and her group actually tested that they were treating people with exactly that, BRAF MEK inhibition plus pembrolizumab, and the response rates were very similar to just BRAF inhibition alone in anaplastic. So again, is there synergy? Do these things help each other out? Not clear. But the real question is, if that's the case, if also for lenvatinib plus pembrolizumab, if there's synergy, if these things help each other out, the question is, will the long-term responses be similar to what we see with just immunotherapy alone? Because that's the cool part about immunotherapy. People can actually respond beyond the end of treatment. Is that a cure? Well, we don't know, but in some cases it sure looks like it. It may or may not come back. Who knows? But it's too short so far. We only have a couple of years of experience with that. But that's the promise. Can we? And then of course, can we cure anaplastic? I think we can. I think 10 years from now we can. I mean, I think we already are in a few cases. Again, making that jump from long-term remissions all the way to cure. We'll see. But I think in some cases we already can. And just given the progress that we're making with immunotherapy, and that's just not just with not just in thyroid cancer, but also in all other types of cancer. That'll spill over into thyroid cancer care. And I'm convinced that 10 years from now we can cure these things. So if you have Hürthle cell or anaplastic thyroid cancer, the trick right now is to stay around and survive the next couple of years. Things like these, our trial, other trials. There's new stuff coming out all the time. There's also now cell therapy coming out. It hasn't worked very well in solid tumors in general, but it's specifically for anaplastic. And again, trial's not open yet, but it should open shortly. If there's a disease out there that can be cured with immunotherapy or cell therapy, like approach like that, it's probably going to be anaplastic, just because it responds very well to immunotherapy. It does really, and pretty much to not a whole lot else. So what's the time? Oh yeah, we have 10 more minutes. So
and we have, I guess I'm going to ask you a couple quick clarification questions that we've seen that I know you can answer quickly, and then I'll move on to maybe a little bit harder. But we had clarification to reminder of what were the two targets of your bispecific antibody that you were just discussing?
PD-1 and CTLA-4.
PD-1 and CTLA-4.
CTLA-4. Yeah, so it's spelled like this is very small, and the alpha means like anti. So CTLA-4, and then PD-1. Let's see. And
when you have PDOTS here, the P dots in thyroid cancer, and what is that referring to?
Yeah, right. No, so this is that model system. So this is this little device here. So it's very cool. There's also a little movie, because they meaning like so David Barbie, but also a guy at MIT who also developed this. They're now selling this to researchers, and so they took the time to put this little movie together. So essentially what this is there's a little it's not loading very well, but there's a little collagen cylinder. It's 1 centimeter, so it's about half an inch long. It's just a millimeter or two wide. So it's very small. And then you put these, you come here with the pipette and you then fill this channel with some cell culture fluid. And the cell culture fluid sort of circulates here, goes in here, goes out there. And then on the other side of the channel, some of that diffuses through that collagen cylinder, goes through here. And then you have, so essentially that's the exhaust pipe. And that's where you can then measure if there are you can look for any markers of the of inflammation. So in this case, we looked for TNF, which is something that inflammatory cells produce, or interferon gamma, or interleukin 2. So it just tells you, something is going on, and that's what we did. So this is a view of that cylinder. You can see it has sort of these, it has a serrated edge, so to just keep that cylinder in place, but the cylinder essentially goes up and down like this. And then you have these little cell colonies, just a handful of cells together with their immune cells living there, and then you can stain them and you can do all kinds of stuff with them. And it was the first system where you could actually evaluate the tumor in vitro, like outside of the body. Mouse models work not essentially because you have to have a mouse that doesn't have an immune system. So you can't really check for immune response in them. They also have a very different immune system than we do. It's a little bit of a hassle. So this was the first system that allowed us to look for response in vitro, and yeah, it worked beautifully. And then that was the basis for the clinical trial. But that was for so we used nivolumab, also known as Opdivo, also again very frequent on the news or in the the advertisement segments of the news, and ipilimumab, which is the CTLA-4 antagonist. That's also known as Yervoy, Yervoy, I believe. I have no idea why they give it such a weird name, Yervoy. I mean, who can think of that? But anyway, that's what it is. As I also said, these drugs are FDA approved, so you can get them. The problem is, and I've certainly treated people off protocol with that combination. The problem is that, we're putting this out. This will be published very soon, but right now insurances usually don't cover it, and they're extremely expensive. They're something like 30,000 a pop. Meaning and you give that every one drug every 2 weeks, the other drug every 6 weeks. There are then assistance programs, and it goes back and forth. It's essentially like a 2-week long process to get this drug, but you can. But in the clinical trial, the drug is free. It's a clinical trial. And it'll be open. It's right now we have it open it's our trial, so it's open at Northwestern. It will be open at MD Anderson and at Dana-Farber, and perhaps also at Johns Hopkins. So we got sort of the big regions covered. But that'll, until it opens in the other places, it'll probably be 2-3 months.
We have one hand up from the audience. I know we only have about 5 minutes.
Good morning. Can you hear me?
Yes, very well. Good morning.
Thank you. Thank you so much for this discussion. I just had a question about research happening on familial Hürthle cell. My mom had Hürthle cell and passed away last year, and I had Hürthle cell about 10 years ago, and was treated with thyroidectomy and RAI. And so I'm just wondering about the genetic forefront of, and we had no identifiable mutations, and so trying to figure out what's happening genetically.
Yeah, that's a really cool question. I have never come across a family with Hürthle cell. But of course there are not infrequently there are families where papillary thyroid cancer, for example, is notorious. Also things like MEN, which typically causes medullary thyroid cancer, but also that's something that's associated with RET mutations. That can also cause papillary thyroid cancer, and there are families that have that. Hürthle cell, no, and that's fascinating. You should definitely, have somebody, us or somebody else, look into that, because these are, the mutations that we know of, either there are these mitochondrial mutations, they're passed down through the generation. So from your mother, not from your father, but from your mother. So that would actually argue in the direction that this is actually not something that's in the tumor per se, in the tumor DNA per se, but perhaps in the DNA of the mitochondria, which are these, weird bacteria-like things. So that's fascinating. I would, it's pretty much, it's strange that, this abnormality that's happening in Hürthle cell, this near complete haploidization, where you lose essentially one set of chromosomes entirely. It's weird that you would, that would happen then through the generations, because if that happens, say, you can't survive that. You need two sets of chromosomes. I mean, if it's just, Down syndrome, trisomy 21, it's like, I mean, and that's a minor change in the chromosomal structure. You cannot survive with just one set of chromosomes. So this is not something that's a germline abnormality, which means that it's in every single cell of your body, something that you were born with. It has to have happened in the cells, in the tumor only. So these are then what's called somatic mutations. It would be very cool to look into that. But I suspect if there is a connection, it's probably through the mitochondria and not through the mutational profile that you get when you just sequence the tumor DNA. What's also odd is that the mitochondrial DNA is amplified if you just sequence. In any of these panels, there's mitochondrial DNA, so the information is there. Because there are just so many mutations in mitochondria, in general, it's usually dismissed as trash. It's just But in a case like, I think your case would, that would be a very strong case that this is actually related to the mitochondria. Now, could it also be related to something that you share, something in your immune system that you share with your mother? And I think that's the other possibility. Just because what we saw was that Hürthle cell was so responsive to immunotherapy, the immune system plays a huge role here. And is that, so is it something that you and your mother have in common? This, some way to being unable to detect your immune system, unable to detect early forms of Hürthle cell cancer, and thus allowing it to thrive and develop. But yeah, fascinating. For the papillary thyroid cancers, where you have a lot more of these families where it goes sort of from generation to generation to generation, there's a couple of people who look into that. And every once in a while, there's a gene. Oh, now we have a gene, and then it gets a nice paper, and then some other people start looking and they don't find the same. And it's been very frustrating. These linkage analyses, where you essentially construct these family trees, and then you get blood samples, not just from people who are affected, but then also from those who are not affected, which allows you then to compare, what's normal, what's not, and so on and so forth. Those are very, very, very complicated. It sounds easy, but it's not. It's a huge undertaking. Yeah, I've never heard of some familial Hürthle cell. Obviously, could it be chance? It also, of course, has some implications. I mean, if it's mitochondrial, you could pass it on to your kids. If your sons then could, for example, not, because mitochondria are only inherited by the mother. I mean, your sons could have it, but they could not pass it on. So yeah, amazing.
Thank you.
I'm glad it sounds like you're both doing well. So I'm glad about that.
My mom passed away last year.
Oh, she did. Oh, I'm sorry.
Yeah. It was very, very aggressive. Yeah.
Wow.
Yeah.
Did she, if you don't mind my asking, but did she get immunotherapy, or did she respond to any of the lenvatinibs or everolimus or anything like that?
She had lenvatinib followed by pazopanib that did not respond, and then she had Keytruda, which had adverse side effects.
Okay.
And no response.
Okay. Okay. Yeah. 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 As I said, everolimus, old drug, rapamycin analog works beautifully in Hürthle cell. That's something to, that often, yeah, it's just overlooked. It's another option.
Thank you so much.
No, we're a little over time. I guess one kind of summary question, we've talked about a lot of different immunotherapies, and someone was asking about kind of the differences, because we've talked about different types of immunotherapies. Are there differences? And as far as the effects of these and extending overall survival, we've discussed many different types here.
Yeah. So there aren't, it's odd. Immunotherapy started out about 10 years ago with pretty much these same two drugs or same class of drugs that are still around. One, the PD-1 inhibitors, and the other for which there was a Nobel Prize, and the other for CTLA-4 inhibitors, another Nobel Prize. And those are still the ones that have FDA approval and are used clinically. All the other, there are many other targets, another, immune checkpoint inhibitors, as they're called. Strangely, 10 years later, none of them have yet panned out. So that can mean one of two things. Either, the other ones don't work as well, or we can't target them effectively yet. Or the drug, basically the flip side of that is, or we produce too many side effects by trying to do that. But, there's, if you think back in the 1990s, when immunotherapy, where tumor immunology started out, everybody thought this is going to be way too complicated. We will never be able to treat tumors with immune therapy. It's interesting. There's clearly a lot going on, but we will never be able to target that, because either it's not going to work, or we're going to just kill people by destroying their immune system. And, for the most part, and then until PD-1 and shortly after CTLA-4 came about. So it really depends, and it just takes time. There will be more. I think the fact that also cell therapy so far has had a little bit of a bad track record in solid tumors, eventually it'll work. It works beautifully in leukemias and certain lymphomas. It's just a matter of then getting the right balance, getting these cells into the tumors in the sufficient quantities, overcoming certain, certain changes in the microenvironment. For example, inside a tumor, the environment is very acidic, and that's because tumors grow so fast, they become very hypoxic, and then they produce lots of lactate because they burn glucose and make it into lactate. It's not very efficient. The mitochondria actually work much better to make energy, but that's what tumors then do, and they're desperate to grow. So the environment is very acidic. So now there's also, for example, a number of antibodies that work specifically in an acidic environment. So they bind specifically when there's a lot of acid around. So that gives it a certain specificity. And we were testing that in another tumor, not in thyroid cancer yet, but we're working on it. And I hope that we will at some point. And there's just it's just one or two examples. There's a lot of stuff going on. It's really amazing what's happening right now. So eventually it will work, and that's also where sort of I'm just an optimistic person, I guess. But I am also. I think it's not just crazy. I think there is a lot of optimism, and that just seeing what happened over the last 10 years, I think in 10 years, we will have a good handle on nothing is ever 100% in biology and in medicine. But I think there will be the day where we, and not too far, where we will say, we can cure 60, 70+% of anaplastic thyroid cancers and Hürthle cell cancers, and deal with side effects in a better way. These are still, the drugs I said, the drugs that we're using right now, these are still the drugs of the first hour, still the same, and their patent now for 10 years, it's going to expire fairly soon. It's still the same, but there's a lot in the works, and it'll just sort of, just like that, it happens always in these steps. There's always the one jump, and then it sort of goes off, and another jump is coming. It's another step is coming. Clearly, it's just a matter of time, and that's why I'm saying, got to make sure you hang around, so you can enjoy all this.
Well, thank you so much. I think I know we're a little over, so I think that's a perfect way to end it with that optimism. We really appreciate you taking the time to walk us through the exciting advancements and answer some questions. Like you said, just holding on for that next round of a lot of exciting new innovation coming. So thank you so much, Dr. Lorch, for taking the time this morning.
My pleasure. Thank you so much. Good luck. Bye-bye.
Thank you, Doctor.
Thank you.
Thank you, Britt.
Thank you so much.
Oh yeah, no, thank you. And yeah, all the best.
Thanks.